I've been doing this for last 20 years now. So I've worked in various institutes in the UK and Canada. And over the years, I realized that there are some areas that need a bit of attention. And this particular area, acute oncology, is going to be a very important area very soon. So we are going to explore more about acute oncology. Okay. So I'm going to start off with the basics. So what's oncology? Most of you will know oncology is a specialty or a subspecialty of medicine or surgery that deals with the diagnosis and treatment of cancers. Okay, so the uniqueness about oncology is, let's say if you do pulmonology, you will be dealing with lungs. If you do gastroenterology, it will be the GI system. If you do cardiology, it's going to be the heart system. But when it comes to oncology, you will interact with all specialties. You will interact with neurologists for brain tumors. You will interact with the breast cancer doctors. Switch on the light, please. Charger. You will be interacting with the gastroenterologist for GI malignancies. You will be interacting with the hepatologist for liver malignancies. So you will interact with lots of disciplines. Okay, hemato-oncology is slightly distinct because we deal only with blood cancers, but invariably we liaise with a lot of other specialties as well. So oncology is quite a broad specialty as opposed to many other specialties which tend to be very narrow. So ophthalmology is extremely limited to eye-related problems, but oncology is quite broad. And now I'll tell you what's going to happen in the next 10 years. Okay, so essentially, if you want to become an oncologist here at this point, so after doing your MD or MBBS, you will proceed to do internal medicine training, a lot of you, that is, or surgery. And then you proceed to become a medical oncologist or a surgical oncologist or a hemato-oncologist or a clinical oncologist, also called as radiation oncologist in the US. Okay. Now, once that's done, that's when you enter into clinical practice in oncology. Now, what happens at that point is you have missed out an area of interface where acute medicine and oncology interfaces. And that's what I'm going to explain in this next slide. And that's why your generation should know this, because this is an excellent opportunity for career advancement. Not many people will think in this direction. So acute medicine is nothing but accident and emergency, as they call it, or casualty or emergency department. Different countries have different terminologies. But essentially, what is acute medicine? When somebody becomes acutely unwell, they go to hospital. That point is called acute medicine. Now, when an acutely unwell cancer patient lands in the hospital, or a cancer patient suddenly becomes unwell, or an unwell patient ends up in casualty and then gets investigated and then gets diagnosed with cancer, that whole area is called acute oncology. Now, you may wonder, why is it important for you to know about this specialty? There are a few reasons for it. The one reason which we discuss now is that 5% of all admissions will be acutely unwell cancer patient. So that's very important. The second point is this. In the UK, the cancer incidence is as high as 1 in 2. So out of every 2 individuals in the UK, 1 will end up with a cancer diagnosis for anybody born after 1960. And this is only going to increase. And there is no rule that you cannot have 2 cancers or 3 cancers. It's not that if one has a leukemia, he will never end up with some other malignancy. He can have more malignancies 5 years, 10 years down the line. So the cancer burden is going to rapidly rise over the next 10 to 20 years. And that's why I made that statement. Your generation of medical students will see more cancers than anybody else. So you are in a slightly different position when it comes to dealing with cancer patients, because even your bosses may not have seen so many cancers as what you guys are going to see in the next 10 years. Now, the point I keep asking medical schools is, or curriculum designers is, have you modified your medicine, MBBS or MD curriculum, keeping this in mind? Have you modified it? Have you taken into note that cancers are really increasing in numbers? They will come at midnight. Who will handle them at that point? So this is something which I keep asking my juniors or anybody is, let's say there is a patient with neutropenic sepsis at midnight. Who will you contact? What will you do as a junior doctor? Let's imagine you have become an intern, you're working on the wards, and you are with the junior most nurse on the floor, and a cancer patient who has chemotherapy, his neutropenia becomes unwell. What would your initial response be? Or for that matter, you are on call for the weekend, and over the weekend, you are suspecting a spinal cord compression. Who will you contact first? These are very basic questions, but very important, because if this diagnosis gets missed, then it has medical legal implications for the doctor, the hospital, for the other clinicians. And that is the reason why acute oncology is an extremely important area, because oncologists do not communicate very well with many other specialists, especially the acute medicine guys. So this is an interface specialty. So if you want inspiration to write up something or to innovate something, this is an excellent area. I keep reminding my medical students that you do not need a lot of resources to innovate. What you need is good ideas. With that, you can easily develop your portfolio or boost your CV, as you may want to call it. So this is an excellent opportunity. You may want to go back to your medical school or hospital and ask your wards, what do you do when a patient becomes unwell at midnight? The senior consultant is not going to be there all the time. They are only there 40, 50 hours a week. That's what? 30% of the working week. We have got 168 hours in a week. So a senior consultant or a senior nurse is only available for 40 to 50 hours of that. That's like 35%. Who handles the remaining 65%? It's the junior most doctor and the junior most nurse. And this is a problem we have with healthcare. Okay, so that's the reason why I keep maintaining you can have fantastic hospitals, you can have specialists trained at the best centers in the world, but after 5 o'clock, after 6 o'clock, if the oncologists and the acute medicine guys are not well connected, acute oncology in itself will create problems and will be the weakest link in cancer care. So there's no point in giving extremely expensive medications to patients, having fantastic units, and then when he becomes unwell at 8 o'clock in the evening, nobody knows what to do with it. That's the situation we are having with cancer now. And that's why acute oncology is going to be a big hit in the next 10 years. Okay. So, and the good part with acute oncology is it is not specialty dependent. You can be a chest physician. You can have an interest in acute oncology. You can be an intensivist, an intensive care specialist. You can have an interest in acute oncology. You can be an emergency department physician. You can be a gastroenterologist. You can be a surgeon or an oncologist. So acute oncology is going to touch a lot of specialties, but unfortunately, for some reason, this has slipped out of the radar of a lot of people here. Your seniors, I mean, not you guys. Okay. Now I'm going to get the next slide on. So we are going to do, now there are quite a few oncological emergencies that you need to be aware of, but obviously we cannot cover all of them. So I'm going to cover the two most important ones, okay? And then I'm willing to take questions. Okay, so let's discuss the most important one, which is neutropenic sepsis. Now, in simple terms, neutropenic sepsis is nothing but you have a patient who has had chemotherapy, has had his immune system wiped out, and now we are waiting for the immune system to regenerate. At that point, he develops an infection. Now, it's a very straightforward diagnosis. If you look at it, that somebody who is neutropenic becomes unwell, the question is, what do you do at the time? Okay, I would have wanted to poll on this one, but I don't think we'll be able to do that. Okay. So neutropenic sepsis is a potentially fatal emergency, and it's because we use anti-cancer drugs to kill the cancer, but alongside we also kill the normal cells. And if left untreated, the mortality rate can be as high as 20%. So neutropenic sepsis is the one emergency that you should not miss during your clinical career. Unfortunately, that keeps happening in almost every hospital I have worked in the UK. The acute medicine or the oncologist or the medicine team has missed acute on the neutropenic sepsis. Okay, and that is the reason why there was a huge review undertaken in the year 2010 in the UK, and they spoke to around 600 hospitals. They involved a lot of staff, and they came up with these guidelines. And the guidelines are very exhaustive. So that's the problem with many of these guidelines, is they're so bulky that nobody bothers to read them. But the key point here is provide the patient and his carer with information that this is going to happen. When you give chemotherapy, you are going to kill the cancer cells and you are going to kill the normal cells as well. So yes, the cancer will shrink, but so will the normal cell population. The white cell population will get, they'll just get finished off with chemotherapy. So it's extremely important that the patient and the carer are reminded of that fact, and that if they become unwell, no matter what time of the day it is, they have to contact the hospital or the oncology unit, and they have to attend A&E as soon as possible. So the diagnostic criteria is you have to be on chemo, the neutrophils have to be below 0.5 or 500, and there has to be a temperature of more than 38 degrees. That's important. A 38 degree centigrade temperature, or if the patient is generally feeling unwell. A lot of patients did not receive antibiotics because they didn't fulfill the criteria. There's no criteria. You will not go wrong if you give him antibiotics and then stop it. But it will be a huge mistake waiting for the temperature to hit a certain level, i.e. 38, and then wait for the antibiotics. So if the patient is unwell in any format post-chemotherapy, a few days post-chemotherapy, and he's found to be neutropenic or is expected to be neutropenic, you don't have to be neutropenic, you can expect. So that typically happens 7 days after chemotherapy for 7 days. So you just have to remember it in that format. Post-chemo, 7th day onwards, they become neutropenic for up to 7 days. You do quick sets of bloods and blood cultures, liver functions, renal functions, lactate, CRP, and then give him broad spectrum antibiotics after checking for penicillin allergy straight away. Within 60 minutes is the deal. Check with your microbiologist in your medical school or hospital, what is your first line chemotherapeutic agent, antibiotic agent you use for neutropenic sepsis. Write down the name of that medicine and the dosage, because you need to know that offhand for that particular hospital. So you may, during the course of your training, you may work in 4 hospitals. I worked in like 8 or 9 hospitals. Some hospitals had slightly different protocols depending on the local microbiological studies. So one of the first things you do when you start off as interns is contact microbiology and ask them, what is your first line antibiotic for neutropenic sepsis? What is the alternative for patients with penicillin allergy? And who do I contact if I'm run into trouble? Sometimes even registrars would not know how to answer this question. And you will end up calling a consultant who may or may not be helpful. If he's on call, he may not know the protocol. He will expect you guys to know the protocol. Now, in the past, we used to give gentamicin or aminoglycosides very liberally. The main feature of this nice guidance released by UK in 2012 was to remove the gentamicin or the aminoglycoside. They just said give tazocin, which is nothing but piperacillin and tazobactam, within 60 minutes of suspecting neutropenic sepsis. So in this webinar, even if you forget everything else, if you remember that acute oncology is a fantastic area where you can do a lot of work, and that I should be giving antibiotics to anybody who becomes unwell post chemotherapy, a broad spectrum antibiotic, that itself, you've pretty much grasped most of the focus of this webinar. Okay. And then inform your seniors. Now you are medical students, so obviously you will become interns first and then become senior house officers or equivalent levels of the hierarchy. So your job is administer the antibiotic after checking penicillin allergy and inform your senior and inform the oncologist as well, so that they come and review this patient within 24 hours. So that is the key takeaway for neutropenic sepsis. Neutropenia occurs post-chemotherapy, especially from the 7th day onwards. They tend to become unwell to the 14th day. That is when they are really vulnerable. And if they come to A&E, do not keep them waiting. You take the bloods, you can give the antibiotics without waiting for the blood test results. This is one of the few areas in medicine where you're licensed to give an antibiotic, a powerful one that too, without waiting for blood results. So you speak to your microbiologist. Whenever you join a new hospital, you go to the microbiologist, you check with your local oncologist and your internal medicine consultant as to where I can find the neutropenic sepsis pathway. And we'll discuss one more oncological emergency, which is spinal cord compression. Now, this is again an acute oncological situation wherein the malignancy, let's say it's multiple myeloma, a form of blood cancer that has spread to the vertebral bodies. And the problem is, it is typically underdiagnosed. Again, a lot of malignant spinal cord compressions get missed out by almost every hospital every year. And once you see somebody who has lost the power in his legs because of a treatable cause, you will try to understand what I'm trying to say here. So it's a very treatable cause, but the problem is nobody diagnoses it. The spine is richly supplied by blood vessels and the lymphatic system. So it's very easy for cancerous cells to go into the spine. And that is the reason, for some reason, we find these lumps of cancer cells destroying the vertebral bodies, causing spinal cord compression. So the patient may report that he's got some back pain, or may have some sensory symptoms, or some urinary symptoms. So they may not report a lot of complaints, but if you keep this at the back of your mind that there could be an impending spinal cord compression, you will then quickly arrange for an MRI scan. That is the keystone here. If you suspect spinal cord compression, no matter what time of the day it is, you will arrange or speak to your seniors, your medical seniors or your team seniors, and request for an MRI scan urgently to make a diagnosis. And no radiologist. Again, this is one area where you may have to deal with 5 specialties. I'll come to that now. And the main aim here is not death, but preventing paraplegia. So in neutropenic sepsis, it was a life-threatening emergency. Spinal cord compression is a limb-threatening emergency. Both of them are preventable, but unfortunately, you will see them happening in the wards. And the treatment from your end is start them on steroids, dexamethasone steroids. But as a junior, even if you do an MRI scan and inform your attending, that's more than enough. You've pretty much done what needs to be done. So these are the specialties that are involved when you're suspecting a spinal cord compression. So you will be typically working under a medical team. You will need to speak to the radiologist to arrange an urgent MRI. MRI scans are typically discussed with the radiology consultant before they approve it. So you will end up contacting them and explaining why you think this is a cord compression and why you need to scan this individual urgently. And then you will be speaking to the neurosurgeons for an opinion. You'll be speaking to the radiation oncologist for an opinion, and you'll be liaising with the oncologist. Now, all this, you can see 5 different specialties are getting involved. And on at least 10 occasions on the weekend, I was on call. This has happened, at least 10 occasions. And you end up contacting all these doctors, all these consultants, so that you can get a quick MRI, get steroids, and start radiotherapy or surgery to prevent paraplegia. So acute oncology is slightly different to a lot of other oncological practices, wherein you get a bit of waiting time, but not with acute oncology. Acute oncology is what it says. Things have to be done fairly quickly. Okay? So the key takeaways for neutropenic sepsis: when you suspect it, you give broad spectrum antibiotics, and you speak to the microbiologist to find out what the choices are. And if it's spinal cord compression, you have to have a plan beforehand. If you, let's say you go and talk to your team tomorrow and ask, where is the spinal cord compression pathway of this hospital or this medical school? And ask them, who do you contact on a Saturday night or a Sunday afternoon? Do we have their numbers? Do you know who's the neurosurgeon who's going to look at the scans, or the radiotherapy doctor who's going to come and give radiotherapy? And you'll be surprised to see what kind of answers you get. So that is why this has to be simulated in advance. You can't wait for a patient to land. This has to be created in advance. You should have all the numbers, all the contact details of all the local hospitals, because sometimes you will not have all 5 services in one hospital. The neurosurgery is somewhere else, the radiotherapy is somewhere else. It's only the medicine consultant and the radiologist you have on site. So you may end up liaising with 3 hospitals. So it's very important you speak to your bosses tomorrow and ask, what would you do if somebody comes with spinal cord compression on a Sunday afternoon? What do you do? And see what the answers are. Okay. So I'll leave it for now. I'll take questions, because it'll be interesting to see what you guys have to say, and I'll try to answer them.
Thank you. That was very insightful, at least to me.
Yes, definitely. Sorry.
Yes, thank you very much for the nice presentation. For the questions, our participants can just type I in the chat, then so that I can give you a chance to speak and ask the question directly, or either you can type your question and then we can address it. Then now we'll be taking your questions regarding this presentation to our guest.
Just for explanation, there's one question, but just for everybody else real quick, for explanatory purposes, we have this method of raising our hand, so to speak, with an EMSA, which means that we type an I. That's what Iram meant. So if you look in the chat, if I want to, for example, now speak, I put an I, and then Iram can call on me, just for everybody to understand. But Alexandra did have a question, Iram. It's in the chat.
Yes, so the question is, what do we do as interns or young doctors if we raise one of these problems and seniors do not take us seriously?
That's a good point. But do you know what? That's a very interesting point. And I have faced it a lot. People tend to underestimate you, especially as juniors, but they forget the fact that they were also juniors 5-10 years ago. Okay. Now, there are 2 ways of answering that question. One is the clinical way, is if you provide very clear clinical information for that particular case, it becomes very difficult for somebody to refuse it. Another option is, a lot of conditions are associated with some very key words. Okay. So let's say you are putting in a request for an urgent MRI, for requesting an MRI scan for a suspected spinal cord compression, you can put in block letters, we want to prevent paraplegia. The medical legal owners has now gone to the other party. They have to now defend themselves. If you say, I want to do MRI, they will say, why do you want to do an MRI? Okay. And if you don't know why you're doing an MRI, then they will say, well, you find out the reason and then come back to me. But the easiest way in medicine to get another department involved is you tell them what will happen if that procedure doesn't get done. So you tell them very clearly, there's a risk of paraplegia. No radiologist will refuse that request because they are not sitting by the bedside of the patient. So you have done the clinical assessment. You say, I want to prevent this patient from being paraplegic and wheelchair bound. Can you please do this MRI? The answer will be yes from a radiologist if they act difficult. If your seniors don't know, this is what we are trying to do. You have to, if let's say you have a neutropenic sepsis pathway, then senior interference is reduced. If you have a very clear neutropenic pathway in the accident and emergency, on all the medicine wards, in the cancer chemotherapy unit, then the need for contacting your registrar or your consultant every now and then is reduced. So that is why I keep saying, be prepared before these patients land in front of you. And as I mentioned, for every condition in medicine, try to find very, very key words unique to that condition and some points that can, some things that can happen if that diagnosis is missed. It is very easy to convince the other party. Let's say you are working in medicine, you want to admit somebody to intensive care. You will then speak the intensivist language. You won't speak medical language. You're a medic, you want to get an operation done by your surgical colleague, you will speak in their language. Okay.
Thank you very much for the answer. And by the way, for the attendance check, we will send a form at the end of the questions part. So please don't leave the session. As we mentioned, we want to give the certificates, but we also want to make sure that you are here and listening to our dear guest. Now I see Ayçin Izzettin. You can now speak and ask your question.
Hello, thank you for this educational presentation. It was really beneficial. But I have a question. I'm a third-year medicine student, and I haven't seen any clinical sides of the hospital, nor any cancer-related studies. So how can I raise myself to be more aware of acute oncology patients who might come to the clinics next year when I go to the hospital?
Okay, yeah, so different med schools have different formats. In some schools, you start from first year, in some it's like third year. That doesn't matter really, you don't have to worry about it. Once you enter your clinical rotations, let's say you are getting a placement in a medical ward or a surgical ward, you can ask them, what do you do for your, when a cancer patient is admitted here and he or she becomes unwell, what do you do? Who do you contact? Is there a guideline? Is there a handbook? My point is, if the incidence of cancer is 1 in 2, i.e. every second person in the UK is going to get a cancer, shouldn't we be spending more time educating ourselves about cancer and acute management of cancer emergencies? But it's only when you start going to the wards and asking the nurses, what do you do when a cancer patient becomes unwell? You start realizing how ill-equipped a lot of hospitals worldwide. I'm not saying this is a problem only in the UK, it's worldwide. I worked in Canada, I worked in different countries, and this is a problem which you will find in almost every hospital. So if you proactively come up with something for an acute oncology pathway, your seniors are going to appreciate that. A lot of doctors go to a job interview and say, at a consultant level, I'm just giving you, I'm sharing a personal example of mine. They go to this consultant interview and say, you know what, I need this equipment, I need that ward, I need 10 more staff nurses, 4 more doctors, and then I will provide this new service for you. Compare him with somebody else who says, I will work with whatever resources you have, but I'll ensure that these resources work in more coordination with each other. Who do you think the financial officer is going to like? And that the second chap goes and says, I will save money for this or hospital or trust by making diagnosis earlier. We will ensure cancer diagnoses are not delayed. We'll reduce the risk of medical legal risks and distress to the patient, the carer, the doctors. But I don't need too many resources. So unfortunately, it's a myth that to be innovative, you have to have lots of resources. That is not the case. There are some countries with very high per capita income, but they are not innovative. Okay, so innovation or creativity is not linked to resources. A lot of us medics falsely believe that if we get a brand new hospital, things will improve. It will not. It will go back to status quo. It is how you use it. So you have resources. If you use it properly for acute oncology, let's say, that will be as good as inventing or creating a new drug. Okay.
Thank you so much.
Thanks for the answer. Now we have Selin Özyıldırım. So you can ask your question, Selin.
Hello, can you hear me?
Yeah, sure.
Sir, first, thank you for your precious presentation. It was really useful. I was going to ask that, is there anything additionally if we are taking care of pediatric patients?
Very good point. Now, childhood cancers or pediatric cancers are treated different to adult cancers. There are lots of differences. Children are not diabetic, they are not obese, they are not hypertensive, they don't have dementia. So they have different kettle of fish. So they get lots of chemotherapy compared to adults if they get diagnosed with cancer. Having said that, the pediatricians, I must give credit to them that they have done better than adult physicians and adult surgeons in that they are much more particular about these things. So whenever I visited a pediatric oncology ward, what I've seen is they are much more aware of protocols. They are much more prompt. They know exactly what to do when their kids become unwell. But that has not translated to adults yet. So if you are going to work in a pediatric ward, you will be surprised to see how well they manage their cancer patients as opposed to the adult cancer patients. But then the numbers are low. You know, the adult cancer patients, the numbers are much higher. So if you go to an adult cancer ward, you will see one nurse handling 20 patients or 12 patients. Whereas in a pediatric ward, it will be one nurse handling 3 or 4 children. So I think on that front, pediatricians are way better than us adult physicians, adult oncologists, or adult surgeons. Surgeons who treat adults, okay? That's what I think.
Thank you so much, sir. Have a good day.
And you.
And another question coming from Bendix is, in case of the spinal cord compression, can a CT be used instead of an MRI, e.g. if the hospital does not have an MRI? Okay. Would we prefer CT instead?
That's a good point, very nice point. The only problem is the neurosurgeons will want an MRI. The radiation oncologist, before giving radiotherapy, will want an MRI. I understand your point. I have done this argument 10 years ago with my radiology consultants. Can we not get done with a CT? It is good, but for getting the exact definition, you need an MRI scan. And so the way to work is, I don't know why you're asking me this question. If you feel your setup, is it because there is no on-site MRI available? If that is the case, you should have a link established with a nearby MRI center beforehand. If you feel the radiologist managing that MRI is not very friendly, then you may have to have a chat with him in advance. We will be requesting MRIs. Do not refuse them just because you're not on site. Why did you ask CT versus MR, just out of curiosity?
Because I've worked in a hospital where they don't have an MRI. So that was the idea behind it.
Sure. If that is the case, you will need to find the nearest MRI center, because see what is going to happen is you will get a CT, but then the next step is who will look at it. The radiologist will look at it, but the neurosurgeon will want to look at the scans before he does anything. The radiotherapist will want to look at the scans before he starts radiotherapy. So the next question, logical sequence is, you are going for diagnosis and then therapeutics. At that point, better to link up with a center with a neurosurgical facility and an MRI scanner. Where are you calling from?
I'm calling from Germany, and I've done an internship in a small hospital, and they have CTs, but they don't have an MRI. So yeah, that's the question.
Interesting point. Yeah. So in medicine, we follow this hub and spoke model. You have a central large hospital and then lots of feeder hospitals. So in such a situation, it's very important you establish a relationship with the radiology, radiotherapy, neurosurgery department in advance. Ask your boss tomorrow, what would you do if there is a spinal cord compression and you want to give radiotherapy or neurosurgery? Very interesting to see what the answers are going to be like.
Okay, moving on to the next question, coming from Hussein. Because of current situation of hospitals due to COVID-19, do you think there is less possibility of diagnosis of neutropenic sepsis?
Yes. Can you repeat that question again, please?
Yes, because of current situation in the hospitals due to COVID-19, do you think there is less possibility to diagnose neutropenic sepsis?
Okay, now there are two reasons. I don't know if you're asking, are we seeing lower incidence of neutropenic sepsis? That may be possible because fewer patients have received chemotherapy in this last 1 year. A lot of chemo got delayed, postponed, cancelled because of COVID. So, which is, it's bizarre because cancer patients should not have their treatment curtailed because of a viral infection. But anyway, that's what has happened now. So that's probably the reason why you're not seeing a lot of neutropenic sepsis. But you will start seeing that once COVID settles.
Thank you for the answer. I think we addressed the pediatric patient question. And there's another question coming from Sumaya. Is that a problem we haven't seen cancer patients enough to treat?
No, can you clarify that question, please?
Is it a problem that we haven't seen enough patient cancer to treat? I think it means that we don't see them very often during the medical education course, at least the undergraduate one. So would it cause much of trouble, or is it something that we can still manage, maybe even after undergraduate medical education?
Yes, now that's the reason why I'm pressing for this entire medical education curriculum to change, to include special rotations on the cancer wards. If the incidence is so high, 1 in 2, 1 in 3, then should the curriculum not be adjusted so that medical students get a chance to rotate in a cancer ward or a hematology ward or a bone marrow transplant ward? So this is something which we will need to discuss later. We may have to contact the medical curriculum designers to incorporate this. So that is the reason why I took a poll, just to find out how many of you are happy with the training you are being provided in your medical school. And this is not just Europe's answers, this is exactly what is happening across the world. Same in North America, Asia, Africa, everywhere. It's the same story. But we are looking at a pandemic of cancer now in the next 10 years. And we want medical students to be fully aware of that.
Definitely agreed. Another question is coming from Enes, and you can speak now.
Okay. Hello, Professor. I'm Enes Sijar from Turkey. First of all, thank you for your good attention and contribution. I'm really appreciating there's such a good presentation for me. And I want to make some researches related to hepatocyte G2 cells, which is cancer carcinoma cells, cell lines, as you know. Would you like to recommend any resources or publications or any professors for me? I want to get some information for this issue. Thank you from now.
Which cell line are you talking? Hepatocyte?
Yes, hepatocyte G2 cells in the liver, cancer carcinoma cell lines.
Okay, I mean, the people doing a lot of good work in liver cancer is King's College in London. Okay, So they have a fantastic liver transplant unit and a hepatology unit, both pediatric and adults. So if you write to the pediatric hepatologist or the adult hepatologist or the transplant surgeons, they're very prompt and they will respond. King's London does a lot of work, the ones who came up with the King's criteria for liver transplantation.
Thank you, sir. I'm noting now. Thank you.
So,
Thanks for the answer. And I guess we are sort of in the last question, unless there is more. Joa Duarte, sorry for the wrong pronunciation. But the question we asked is when facing a spinal cord compression suspicion, if by any chance the hospital has no chance to perform an urgent MRI, is it feasible to administer dexamethasone if the suspicion is high?
that's a good point. You can do it, but the problem is steroids are so powerful that very quickly the tumor will start to melt. That is the problem. You will miss the diagnosis. So it is, again, you will again have to find out from your team where your nearest MRI center is. If you feel it's going to be really difficult to get an MRI done, then it is a case for requesting for a machine. An MR scanner is not a luxury anymore. So that is, it makes a big case. If you can prove that in the last 2 years, a spinal cord compression was missed because an MRI scanner was not there, if you present that as a report, you will get a new MRI scanner. And in your CV, you will say that I did an audit, found that a spinal cord compression was missed because of lack of MRI scanner. Based on my audit, we got a new scanner. That shows leadership, that shows proactiveness. So it's very easy to build an impressive CV. Okay,
if I may also add on to that, we also have to remember that in today's age, there is always, or in most countries, the possibility to be able to transfer patients in case the need may arise. So if there is no MRI and you're in the countryside and there's absolutely no way that you can get to an MRI machine in your surrounding area anytime soon, there is a network where hospitals are connected with each other, which they use for mostly, for example, for trauma cases. In that case, if you have a trauma patient, it always also is being asked which hospital do we send that patient to. Similarly, if someone shows up in the ER and you say, hey, we don't have the means to diagnose it, again, you will have to realize that, of course, then the transfer can be made possible. That also requires, obviously, proactiveness on your part to realize, but that should be made possible by your hospitals.
That is correct. So if you say I'm suspecting a cord compression, they will then inter-hospital transfers. There are different categories. They can be airlifted, they can be taken by a blue light ambulance wherein the traffic will have to move out, or they can go by a normal ambulance. So if you say spinal cord compression, they will blue light him. So that is the way you convince the transport department to get this patient to the nearest resource as soon as possible.
Thank you very much for the answer. I assume this is the last question, but if there's any, you can still ask. We're here. And for the attendance purposes, I'm sending this form. Please fill this in, then you will soon receive your attendance certificate to our event. Now floor is open. I was again asked to share your contact information. If you can just type it in the chat, that would be great. We can also email you. Dr. Ravi, if you can just write your contact information for our participants to the chat, that would be lovely.
Yeah, regarding the form, how long is it open?
Around 5 minutes.
Okay, so everybody, you have 5 minutes to be able to fill it in afterwards. That is no longer possible.
It's just your name, your university, and mail to ensure that you have participated here.
Okay.
So what I'll do is I'll just I'll text you my
So Dr. Ravi, you're texting the your contact information to Idem directly, or are you putting it into the chat?
Because if I play with this computer, it will crash. It will
Oh, okay. Okay. So what we will do is with we have your email contact information. We will be emailing you after this webinar as well. That's something that I just wanted to point out. I hope that that is okay for everybody. We will be reaching out to you for maybe also input purposes for other things. Before I hand back over, or actually, Idem, do you want to say anything? Sorry, or Sudha.
Have you got it, Irem? Oh, yeah, that's it. Yeah, cool. That's my site and my
Yes. And
I was
also,
like- okay, thank you.
yeah, you can find Dr. Ravi on LinkedIn as well. I will just try to look for the link, but if you just type his name, you will find him. And I already have your personal email. I can type it here if you don't mind, since we communicated through emails.
Sure, no problem.
Okay, I'll be sending his email as well. And Sudha, if you have some maybe closing words, that would be lovely.
Thank you all for joining us on this lovely Sunday. It was really nice to hear from you, Dr. Ravi, and thank you for taking the time to educate us.
No problem at all.
On my side as well, in the name of the executive board, thank you very much for being here, Dr. Ravi. It was very insightful. As I said, I'm in my 5th year. I'm meant to go into the patient care very soon. And still I was not aware of it. And I did actually do internships voluntarily on the oncology ward. So it's very interesting to see that there's still some things that should definitely, in my opinion as well, be included into the medical curriculum as a core subject or a little bit more emphasized. So thank you very much for that. As I said to everybody else, we're going to be reaching out to you guys via email. Thank you all for being here. We had a very high number of participants, over 110 people. And at some point it was 128. I don't know, some people I think dropped, probably also with internet problems. Thank you also for sticking with us through the internet or connectivity difficulties. And yes, please, well, enjoy your Sunday evening or afternoon, depending where you are.
Brilliant. Hope to speak to you guys soon. We'll do another. Try to cover some other areas of acute oncology and how you can try to do an audit and try to publish some papers.
Yes.
Thank you very much for the presentation and lovely participation. And do not forget to please fill our form.
And if you have any, if you as participants have anything you want to say to us, you can contact us through, Idem, do you want to put your email address, or so do you want to
Yes,
put yours?
sure.
And let us know anything you want to let us know. And I also thank you in the name of the executive board for being here today.
Brilliant. Thank you, Alexandra. Thank you, Emsa. Thank you, student, and thank you, Rem.
Bye-bye.
All the best.
Thank you, everyone.